Well, welcome to the webinar on reducing the risk of infection in the operating room. We have a multi-specialty discussion of some surgeons, and I'm an infection preventionist. We have with us Dr. Christopher Basile, Carlos Aguirre Rieta, Kyle Muller, and my name is Maureen Spencer. So here are our faculty disclosures. And the program has been provided by the North American Center for Continuing Education, an HMP global company. It's also supported by an educational grant from Airobiotics. So our learning objectives is to understand the risks of surgical site infections, particularly in lengthy procedures, identify various ways to reduce surgical site infections, and understand the difference and impact of non-turbulent air purification during a surgical procedure. So I'm going to turn it over now to our first speaker, who's going to be talking on surgical site infections in neurosurgery, Dr. Kyle Muller.
All right, well, thank you very much for the opportunity to present here on this important subject matter. Back pain and neck pain is obviously a major source of disability in the United States. It's very common. And the US spends a drastic amount of money on this. And even though a small fraction of these patients will undergo surgery, that still ultimately becomes a big source of healthcare utilization. And many of these patients fortunately do well, but there's still the risk of developing a surgical site infection. And we should be concerned with this because it does impact all of us. And unfortunately, attention to the optimization strategies has historically been lacking, especially in the field of neurosurgery and spine surgery. And there's many factors related to wound complications that can be a source of discomfort to the patient, to their family, and to the healthcare system in terms of costs. And as we've transitioned to more value-based healthcare, spine surgery has become a focus of how we can provide better care to these patients. And on that front, there's been some studies that have looked at what are some quality improvement benchmarks that we can use as standards. And so the National Healthcare Safety Network report is one of the initial ones that came out. And it showed that for a simple laminectomy, it was about a 1% risk of an infection, fusion up to 2%, and a revision fusion up to 3%. And unfortunately, what many of these initial databases lacked was an attention to the pathology. And the difference in pathology will confer drastically different risks of infection, even with a stain surgical procedure. And this is evidenced by many studies, but these two studies in particular out of the same group that looked at the risk of surgical site infection in a degenerative population versus a oncology population. And they found that the oncology population had almost a 2 times greater risk than the degenerative population, as well as there was other factors that even in this degenerative population led to increasing risk of infection, such as diabetes and obesity. On top of that, there's been an evolution in minimally invasive techniques. And so the traditional midline open surgeries, though still performed, now we're being able to better perform these surgeries while achieving the same goals using less invasive techniques. So what we've developed is now this is a recent paper that kind of summarizes a variety of factors from patient-associated to surgery-associated factors on high-risk individuals. And these are things such as diabetes, obesity, things that we do intra-op, such as neat transfusions, and the degree of invasiveness of the surgery, factors related to putting patients at higher risk of surgery. And so whenever we think about strategies to prevent post-operative infections, we can divide these into perioperative, intraoperative, and post-operative phases of the patient care. And this has allowed us to develop strategies targeting each of these areas on how we can collectively reduce the risk of getting a surgical site infection. Many of these involve preoperative antibiotics, chlorhexidine bath, skin prep, as well as irrigation, and most recently, attention towards surgical dressings. On the surgical dressing front, historically, it's been standard occlusive dressings or glue, depending on the surgical site. There's some local wound care that can be done afterwards to these incisions, but typically just a sterile occlusive dressing has been used in spine surgery. Recently, the use of an incisional negative pressure therapy has been shown to be a strategy to reduce the rate in surgical site infections, as well as especially in high risk groups such as oncology, revision fusions, and deformities. So a strategy that can be used to help that. And collectively, what we'll hope to do is achieve some sort of standardization of evidence-based practices, where we take historically in spine surgery a variation and help to standardize this process, then evaluate that and look to improve it. And so what you'll get a development of is a kind of a complex wound closure pathway that incorporates many evidence-based strategies in a given patient to reduce that risk. And so what this may look like is this is a 63-year-old patient who presented with back pain and was found to have a metastatic lesion to the spine. They would have our surgical goal needing to decompress and stabilize them. But this patient may have certain risk factors. In them, there was numerous ones. They were a smoker, they had oncology, they were malnourished. And the surgical plan to take care of this patient involved a pretty significant surgery. So what are some strategies that we can do to do that? And so in addition to the preoperative cleaning, the antibiotics, the use of negative pressure dressing, all these are done collectively to help achieve a wound that closes even in a high-risk patient, therefore improving the care and value that we give to patients. Incisional negative pressure therapy is a valuable adjunct for this incisional management. It stabilizes the closure and prevents shear. It's not for every spine incision, though, especially with the development of minimally invasive techniques. However, it continues and will still have a role in many spine cases. It's an active surgical dressing that you can use in the perioperative period while you mobilize them, and it should really target high-risk incisions. And it really comes with a minimal change to your normal routine. So you did all this hard work and you don't want to fumble at the 1-yard line whenever you're taking care of these high-risk patients. You want to protect your work. So you want to think about these strategies whenever you're in the operating room, even before the operating room, so that you can take good care of these patients. Now, these pathways become mute if you're operating in polluted air. So does the quality of the operating room air actually matter? This is definitely a very interesting point that's understudied in the field of spine surgery. But this paper here looked at the use of a retrospective study of 180 spine fusion patients. It was a heterogeneous cohort, but it did appear that the use of air technology reducing the infection rate after complex surgery certainly merits further studies, and that certainly makes sense to us that are in the operating room. And so in conclusion, surgical site infections are a significant problem, and they impact all of us. It's all of our responsibility to try and prevent them. Standardization of best practices can help optimize the care of these individuals, and in closed incisional negative pressure therapy is an emerging valuable addition, especially for high-risk patients. And continuous iterative improvements will improve the quality of care that we deliver to patients, and ultimately that's what I think us as surgeons want for all our patients. Thank you very much. And now I'm going to turn it over to Dr. Basile for further discussions in the field of obstetrics and gynecology.
Hello, everybody. Thank you, Dr. Muller. So my name is Christopher Basile, and I'm from Atlanta, Georgia, a private practitioner, OBGYN, and also sit on the administrative staff of the department. I am a pelvic pain specialist, and I am practicing just general obstetrics and OBGYN with that subspecialty in pelvic pain and pelvic floor disorders. And surgical site infections, sitting on the administrative side of Northside Hospital, I'm very in tune with right now one of the biggest objectives with JCO is surgical site infections. And as we're always trying to improve better ways of improving the environment and improving our optimization in the operative field to basically minimize surgical site infections. So in OBGYN, we got the most surgeries that we see with complications. On the obstetric side, we see cesarean sections. And on the gynecologic side, we see the most complications with hysterectomies, prolapse procedures, and laparoscopies. Study done at Johns Hopkins over a 3-year period showed that the surgical site infection rate was about 2.76 per 100 procedures. And that resulted in an average extended hospital stay of 9.7 days, with a cost being a little above $20,000. And in their studies, they concluded that 40 to 60% of these are preventable based on what we call surgical best practices. So there's different types of surgical site infections, and we can go anywhere from superficial to deep organ space. And again, these are just the definitions of these and how deep they go. Similar to what Dr. Muller had talked about, we have similar risk factors for surgical site infections. So age, obesity, smoking, malnutrition, presence of an underlying infection, diabetes, anticoagulation. And then operative risk factors that we have for surgical site infections also include the length of the surgery, the amount of blood loss, if blood transfusion is delivered, and then also the type of wound that we see, just clean versus contaminated versus dirty infected. And these usually respond to the spaces that we're operating on. In the US, so on the obstetric side, we look at there's about 3.8 million births per year. And this number has actually skyrocketed in the last couple years. And about a third of those result in C-sections. So about 480,000 scheduled C-sections are also performed during the year, with the majority of those C-sections being in the southeastern United States. One of the biggest risk factors for C-section is obesity, and we tend to have a large obese population, one of the most obese populations in the southeastern United States. So we start to see these numbers jump up. A study out of Barnes Jewish Hospital, basically evaluating 1,605 patients over a 2-year period. And they found that 81 patients, or 5%, developed surgical site infections. Now, the problem with this study was that it was basically hospital-based. And as surgeons, we know that the majority of surgical site infections are actually treated on an outpatient basis. So here they use their data based on antibiotics during the hospitalization, readmission to the hospital, or ER visits. They evaluated just demographics and comorbidities. And what they found also was just obstetric-related variables. There was the parity of somebody, the mode of delivery, what was the situation with their membranes, if they were ruptured for a long time, if they were induced, what were their induction methods, and their number of exams. Operation-related variables came down to their ASA score, urgency of operation, like basically a stat C-section versus just a regular C-section that's timed for failure to progress. Uterus exteriorization, closure methods. These are all kind of comparisons that came in into the study. They found basically that development of the subcutaneous post-procedure, the operation performed by the university teaching service, a high BMI or obesity, and use of staples, ironically, was also independent risk factors for surgical site infections. Now, how does this affect people? I mean, let's say the healthcare system on one side, if you get the average C-section, a surgical site infection cost can be anywhere from $3,400 to $17,700 in addition. And at a 5% infection rate, if you're comparing that Barnes Jewish study, then it can cost up to $1 billion a year. But for all those who have kids and for those who are one day to have kids, those first 6 weeks are daunting. They're difficult, they're tiring, they're exhausting. You're up every 2 hours. The mom, especially trying to breastfeed. And there's a lot of time and a lot of concerns that happen when infection gets thrown in. You get impact of that bonding time with the baby, the impact on breastfeeding, the additional healing time that it already takes due to a high anxiety and highly stressful time. And then if somebody gets even readmitted, you add difficulty in childcare. So these are all things that affect just the mental status of the patient. Basically, surgery is healed through the immune system, and the immune system basically directs a lot of surgical healing. And in those first 6 weeks postpartum, I'm telling you, the immune system, what builds it, what keeps it strong: sleep, nutrition, exercise, stress management. In those first 6 weeks, you have high physical and mental stress, fatigue, exhaustion. Even though modern medicine is changing, only at this point in time, mom can breastfeed these days. There's jealousy factors of additional siblings that can happen. So a lot of high stress environment. And so their immune systems are definitely subpar, and this affects them drastically. Okay, traditionally, when we look at pre and post-operative infection strategies, preoperative, we got different antibiotics that we can use, surgical site prep. This is, again, going back to the chlorhexidine rinses and the baths that we use, betadine baths, removal of hair from the surgical site, environmental controls, proper sterilization, glycemic control of the patient. Diabetics obviously are a bigger risk. Then we have both intraoperative and postoperative techniques that include wound vac care, hand hygiene, patient education, again, antibiotics, different types of coverings, antimicrobial sutures. These can all play a role into management strategies. Going back just real quickly, I want to touch on kind of the phases of wound healing, because in order to truly talk about surgical site infection, you have to understand how wounds heal. And this is just a quick refresher. So you have the initial insult, and the body rushes quickly to gain hemostasis. This happens through forming a blood clot. You get vasoconstriction, platelet aggregation, and that clot formation. Then it moves on to an inflammatory process. This is where you get swelling, capillary leakage, vasodilation, intracellular edema. This is where you start getting the laydown of the immune receptors, all the growth factors, the tumor necrosis factor, all the interferons that come into play, the macrophages, and you start getting and challenging that tissue and rebuilding it. And then you move on to the stage of proliferation and remodeling. And these are kind of a dynamic process. These both occur hand in hand together. So proliferation is angiogenesis, granulation, and reepithelialization. And remodeling is basically deposition of that extracellular matrix, the fibrin deposition, the tissue remodeling, and the wound contraction. And these are all a dynamic process that can be moving both forward and backwards. And you get an influx of pro-inflammatory cytokines that can come in and help address and remove like poor tissue and help rebuild and remodel that stronger tissue and rebuild and form through angiogenesis, granulation, tissue, and reepithelialization. How do antibiotics and antimicrobials work? Well, they work through several different areas. Antibiotics work basically on attacking the cell wall and coating the surrounding bacteria. They interfere with the reproduction of bacteria, and they block certain proteins and certain protein productions in the bacteria. Whereas antimicrobials, they work on several different areas. So they also attack the proteins of the microbe, and they cause failure of essential functions. They get cell disruption that occurs. You get oxidative damage that occurs, and that leads to significant damage on the internal system of the microbe. And then you get DNA disruption. Basically, when you look at antibiotic resistance, that occurs when antibiotics attack some of the weaker and non-dominant bacteria that are occurring, and antimicrobials attack in different areas. So moving on to the next slide, it brings us up to the source of biofilm. And biofilm is something that everybody in materials management knows a lot about, and then physicians that deal with implants know a lot about. But I think on average, the majority aren't fully aware of the biofilm world. And biofilm is basically the community of pathogens that's essentially enveloped within the complex structure of entangled polymers. The easiest way I say it is, this is the castle, this is the fortress that bacteria tend to hang in anytime you deal with an infection. You got the community of pathogens there are multiple species of bacteria and fungi living together. They're entangled in the extracellular polymeric substance. They create this protective matrix called the EPS, and that's made up of proteins, glycolipids, and polysaccharides, and DNA. And then these are all bonded together through metallic ions and polymers of the EPS, together forming a resilient barrier. So this is basically, the easiest way I say it is, you got the The metallic bonds are essentially, if you ever watch a road being built and you'll see the rebar being laid down and then the concrete laid on top of it, the metallic bonds are kind of like that rebar being laid down and then the concrete on top of it is the matrix, and with everything being protected within it. So this is an electron micrograph of basically Staph aureus bacteria on an indwelling catheter, and that the sticky substance that you're seeing right over here, this is basically the biofilm being created. So biofilm goes back down to this. You got the bacteria sitting within the metallic bonds within this EPS that's in here. And it's essentially this coveted little world that the bacteria goes. So if you think about an abscess, for example, you get the rind behind an abscess and then the bacteria is all encompassed within it. And like take the abscess, for example, as just analogous to this. Antibiotics will attack the outside of the wall, but they won't attack the inside of the abscess. And it's kind of the same thing with the biofilm, that inside protective layer. This makes up the matrix and that protective fortress. And the majority of resistance of bacteria is actually due to the EPS in the biofilm population. Biofilm basically begins within 5 minutes. You basically start with free-floating planktonic microbes, and that forms a conditioning film containing protein, sugars, and blood products. And that basically can happen within a virgin surface within milliseconds. And then you start to get these reversible and irreversible adhesions and coadhesions that occur with the first bacteria colonizers and on the conditioned surfaces. This takes seconds to minutes, and that's number 2. Number 3, you get multiplication of the microbes, and they form distinct microbial aggregates, and these become microcolonies, and this takes hours to days. Then you get maturation of that biofilm via production of the more EPS, and then the formation of the water channels that occur, and then you get microbial hemostasis that occurs right here at level 5. Microbes detach and continue to spread and start the cycle all over again. So again, this is a process. It begins within 5 minutes. And in here, you're seeing when the conditions are favorable and the temperatures are right and nutrients are available. And some bacteria like E. coli, they can divide every 20 minutes. This is Staph aureus, but E. coli can divide every 20 minutes. And that means ultimately, if you think about it, in just 7 hours, one bacterium can result in 2,097,152 bacteria. So as we look at this, successful biofilms are able to hijack and commandeer the host responses. So here you got Staph aureus that's starting to take on some of the fibrin of the host. And you can start seeing it progress from 5 minutes all the way to 24 hours. You can start seeing the progression taking on the fibrin and developing its own biofilm matrix. So again, this kind of comes down to preoperative and post-operative techniques that we use, going back to the similar slide we had beforehand. And out of another study that came out of Ohio State, they compared obese women who were at risk for surgical site infection and comparing cesarean delivery. And this came out in Nature. And these were the non-obese group and the obese group. What they found was that the CFU content of bacteria before PrEP was significantly higher in obese women, but after the PrEP did a good job. However, this is what I thought ironic. Immediately post-operatively, at the last close of the incision, they found that the bacterial content was back up there again. And this is after C-section and treatment. So again, all of these other tricks that we've done, we still had elevated bacterial colony counts post-operatively that were very similar to the preoperative state. This slide is mainly to show these are the 3 most common sources of infection for C-sections: Staph aureus, Klebsiella, and E. coli. This is comparing gels that we use, some gels that we can use to reduce compared to silver barriers, but these are all just added devices that we can use and added products that we can use. Again, controlling the operating room air is really critical as well. I mean, we always kind of view the air in the operating room as the most sterile. However, as Dr. Muller pointed out earlier, there is concern about how the air is maintained. All the different things that we use are trying to reduce surgical site infection. This is, again, huge on the JCAHO docket right now. So in conclusion, C-sections are some of the most common operative procedures we do. Surgical site infections are a worldwide problem. Biofilm is really the crux of what we got to try to tackle It's something that we deal with. We got traditional antibiotics, and we got additional ways of treating and minimizing and reducing surgical site infections. So now I'd like to pass it over to Dr. Higuera Rueda. Thank you very much.
Thank you, Dr. Basil. So I'm going to talk about mainly about periprosthetic joint infections, basically total hip and total knee arthroplasty. The challenge with this is, unfortunately, from the 1990s to the 2010s, we have seen a twofold increase in the incidence of this type of infection, which means that we have had a cumulative number of infections annually by 5%. This represents about $2 billion in expenses for the healthcare system in 2020. So improved prevention, diagnosis, and treatment are desperately needed. Now, unfortunately, once we have one of this, depending on what you read, the true success of treatment of this condition, meaning no infection, no mechanical failure, no reoperation, is barely 65%, which is pretty bad. And it doesn't matter what type of treatment you will use, sometimes one stage or two stage type of revision where you have to remove all the hard work, put a cement spacer, treat it with antibiotics, and then bring the patient back to do a reimplantation. Again, the success rate is not that high, no more than 80% depending on what you read. But most importantly, the 5-year mortality after revision for PJI is about 26%, meaning that having a periprosthetic joint infection is even worse than some of the most common cancers like melanoma, prostate cancer, or breast cancer, where definitely the mortality at 5 years is less than 26%. And this is even worse when we have multi-resistant bacteria like MRSA, when the likelihood of failure is almost 10 times higher. And this is more or less where we were in 2020, performing about 70,000 of this periprosthetic joint infection treatments just in the US. So if you don't want your clinic to look like this, there is something very important you need to do, and it is prevention, as my two colleagues just talked about. So I just want to give you some random facts about what happens in the operating room. What is the rate of bacterial shedding of an operative staff per minute? Is about 10,000 bacteria per minute, which is incredibly high. Why do we use alcohol-based preps more effective manner than povidone iodine alone? Is because of the skin penetration. As we know, the hair follicles and sebaceous glands that store some of this bad bacteria, including C. acnes, is pretty deep. That's why alcohol is better than just povidone iodine. What do we use? Adhesive drapes to prevent lateral migration of bacteria. And finally, after how many hours after prepping does the skin get colonized again? About 3 hours. And this is just to show you some of the different ways that we can potentially get inoculation of bacteria in the wound. There are many different sources. So again, what can we do? Well, let's start talking about the patient and the things that we can modify in terms of risk factors in the patient. Nutritional parameters, patients are malnourished, especially alcoholics. Some have either cancer or GI pathology. We check for transferrin albumin and total lymphocyte count, and we use these parameters that you see in the screen. If you see any of these parameters lower than these thresholds, then these patients need to get nutrition optimization. Diabetics need a significant glycemic control. There is a significant literature showing that hemoglobin A1C should be less than 8%. There's a recent paper from the American Association of Hip and Knee Surgeons, not necessarily per the CDC guidelines, but at least in my world, is very important. Also, it's very important the perioperative glucose. We usually try to target about less than 180 milligrams per deciliter, especially in the first 72 hours of the surgery. As we know, when the glucose is higher than this, the immune system doesn't work as well as it should. HIV patients, we look at the CD4 count. If it's less than 200 or the viral loads is higher than 10,000, these patients should not have surgery. UTI is debatable, but if the patient has symptoms of a UTI, we confirm that there is a UTI. This has to be treated before we perform the surgery. Sometimes in an emergent fashion, when we do for example, a hip fracture, we just give prophylactic antibiotics, including antibiotics like ciprofloxacin or gentamicin that will cover flora for a UTI before we make the surgery. Obesity, as my colleagues just talked about, is a significant risk factor. Some groups, if a patient has a BMI higher than 40, they wouldn't perform surgery. In my opinion, I don't think that that's a good practice because we have a significant amount of obese patients. I believe it's more important just to counsel these patients and educate them and try to optimize their weight and their nutrition, and also adjust the preoperative antibiotics that are used in terms of prophylaxis, cefazolin 3 grams and vancomycin 1.5 grams if the patient has a higher weight of 120 kilograms. In smokers, at least in my practice, that's a no-no. If the patient smokes, won't have surgery with me, has to stop at least 4 to 6 weeks prior to the procedure. And this has been, the link with the pre-prostatic infection has been proven many times across the literature. And we definitely have to say no when the risks outweigh the benefits. We need to have clear indications for surgery. In terms of medications, the American Association of Hip and Knee Surgeons got together with the American College of Rheumatology, and they put some guidelines. The reference is there in the slide, and they give us some recommendations. If the patient is on steroids, if he has more than 7.5 milligrams per day for more than 3 weeks, there is no need of a stress dose. Methotrexate doesn't have to be stopped perioperatively. It shows that the risks are higher than the potential benefits of stopping, so we continue with this medication. Some of the other immunomodulators like leflunomide, we withhold this medication 2 days preoperatively and 2 weeks postoperatively until the incision has healed. TNF-alpha antagonist, there is really no evidence, so we try to help one dosing cycle preoperatively and resume once the wound heals. And all the biologics should be withheld prior to surgery, and the planning of the surgery should be done at the end of the dosing cycle. And a lot of times we do this in a multi-team fashion, talking with the rheumatologists that manage these medications. Staph aureus screening decolonization is debatable. We still continue doing this mainly to tailor the prophylactic antibiotics that we give to the patient. If the patient is MRSA positive, in addition to cefazolin, we give vancomycin as a prophylactic antibiotics. Never vancomycin at all alone, as vancomycin is only bacteriostatic, is not a bactericidal, and doesn't have good coverage as prophylactic antibiotic. Preoperative skin preparation is extremely important. 2% chlorhexidine gluconate wipes the night before the morning off is a really good decolonizer of the skin flora. Across the literature has shown that that's a game changer. We use it now done routinely. Hair removal should be done with electric clippers the day of the procedure. We tell patients they should not shave prior to the surgery. Povidone iodine scrub, applying one layer, covering the whole skin as work as a desiccation. So that's really important, that you need to understand what's the mechanism of action of the different skin preparations. But the most important thing here is the CDC new guidelines recommend skin preparation with an alcohol-based antiseptic agent. That's a 1A category based on the evidence, and that's what we currently use. In terms of prophylactic antibiotics, the time and the dose adjusted by the way is extremely important. For cephalosporins has to be done 1 hour prior to surgical incision. For vancomycin, 2 hours prior to the incision. As I said before, vancomycin routinely if MRSA carrier positive, in addition to the cephalosporin. Patients with penicillin allergy, this is debatable. I'm going to talk about in the next slide about this. But we basically rarely hold a second generation cephalosporin for these patients unless has true history of anaphylaxis. And then it's important in the long cases to redose after 2 half-lives or more than 1 liter of blood loss. Cephalosporin is about 4 hours, and for clindamycin, vancomycin is about 6 hours. This is an award paper in the orthopedic literature from Mayo Clinic, about 30,000 cases From those, 12% got penicillin allergy testing, and from those, 97% that this penicillin allergy test was negative, meaning this is extremely rare. But most importantly, there was about a 32% decrease adjusted risk to develop surgical site infection in patients that receive cefazolin. In other words, when you don't use this like a second generation cephalosporin, the risk of infection is significantly higher. Blood conservation is important. We use tranexamic acid routinely now, either IV, topical, or PO, as we know that excessive anticoagulation is linked to infection. Some of the newer anticoagulants, we published this in 2015, are linked to hematomas, and hematomas lead to infection. The operative room environment is extremely important. However, laminar airflow systems, ultraviolet light, surgical attire, hoods, there is really no recommendation, at least per the CDC guidelines. The main recommendation is to decrease OR traffic. However, this brings to our attention what has mentioned earlier, that the operative environment and the air quality should be kept as clean as possible. This is a paper that we published recently where we wanted to test the efficacy of ultraviolet disinfection and recirculation unit to reduce airborne particles and bacteria. And we did 50 total knee replacements and heel replacement procedures, from where 25 we used this system and 25 we didn't. And you can see how it's localized in the OR. We actually did some pilot studies prior, and independent of the location of the system actually has a significant effect. As you can see, I apologize for the busy slide here, but the total particle count was a significant difference when we used the unit, and the volume of particle count was significantly less as well. However, when we measured the colony forming units, there was no, despite the fact that there was a trend, there was not a statistically significant. But there are some other groups that already have shown that when they use these type of units, the surgical site infection is less. And just for illustration purposes, these lines indicate the opening of the OR door, and you can see the significant increase on the volumes on the total particle units in blue when we did not use this type of filters. And in orange, you can see that it kept the total volume of particles very low, regardless of the opening of the door. So we believe that that's when those changes of pressure, that's avoid these spikes of particle counts. Other additional interoperative strategies try to be efficient and fast, maintain the operative time in less than 2.4 hours. Gloving tips and changes, we usually do double gloving. Change the blades every 60 to 90 minutes, and also after the skin incision. As I mentioned before, you don't want the blades that went through the sebaceous glands to go deep, as there's potential contamination there. No drains if possible. We use povidone iodine wash, also sometimes peroxide or chlorhexidine in basins to keep the instruments clean. And then at the end of the procedure, we use diluted povidone iodine, about 3.5 milliliters per liter soap for 3 minutes. There are 2 level 1 studies that have shown that reduce the surgical site infection, at least for arthroplasty. There are other type of solutions that you can use also. Acetic acid is pretty cheap there. That's something that we use here in our pharmacy, and it can give it to you in a sterile manner. Wound vancomycin powder is debatable. The CDC recommends against it, but there is more literature, especially in the spine literature, showing that it can decrease the incidence of surgical site infection. Doing a prospective randomized study will be very difficult, as you will need about 10,000 patients. However, believe it or not, we are doing a multi-center study evaluating this currently, and hopefully it's probably going to take a couple of years, but we will have the results of this, and hopefully we'll clarify this issue for good. Closure and dressing, my colleagues expressed, is the most important part of the procedure. There's really no literature to support that there is a difference in terms of monofilament versus polyfilament or barber sutures. However, the use of incisional bags, as Dr. Muller highlighted, has shown that decreased wound complications and reoperations. This is a study that actually I did like a couple of years ago, and we just recently reproduced this in a multi-center prospective randomized trial, and we just published it last year. So especially in high-risk patients can play a significant role. So in summary, the PJI is a devastating complication that increases mortality, morbidity, and cost, is unfortunately on the rise, and prevention is the best strategy. Thank you. And with that, I will give it to Maureen for discussion.
Thank you to all of you for great presentations that kind of set the stage for this part that I'll be doing on total operating room air quality control with non-turbulent air purification and an innovative product that's called Illuvia. So if we look at the air quality today, and as an infection preventionist at very large teaching hospitals in Boston, most of it an orthopedic hospital and Mass General Hospital, I spent a lot of time in the operating room and watched a lot of this potential contamination. We know that we can have airborne microorganisms from aerosols that get generated during procedures, smoke particulates that might also have bacteria or even viruses in them, like human papillomavirus, carcinogenic volatile compounds such as formaldehyde, bone and blood aerosols from powered surgical tools, waste anesthetic gases, bioaerosols from skin and oropharyngeal contamination. And it was mentioned earlier about the amount of bacteria that are on our skin squames. And we as humans shed 10 million skin squames a day, of which 1 million of those are bacteria. So, this whole issue of how many people are in the room and, surgical attire becomes, questioning whether this is what's causing some of these bioaerosols that are moving off eventually into the field. And then we have, as it's been talked about, the door openings. And, that's something that some hospitals have developed some innovative ways, whether they tape the doors or have different kinds of signage to prevent people from going in and out, or get runners for the rooms, or maybe have extra supplies in the rooms. It's a real challenge. And we also can have, as I mentioned, airborne viruses such as the human papillomavirus that can come from electrocautery. And then the heater-cooler emissions that came out and caused cardiac infections a few years ago. These were not being really cleaned well. And unfortunately, the water that was in them started to move out into the air and eventually ended up coming into the incisions with a non-tuberculous mycobacterium. So if you look at a new filter versus one that's been in place for 60 days, you can see how really contaminated these get with particles in OR ventilation fans. And this actually is an exhaust vent surface culture I took. One of the challenges I see in a lot of ORs is there's so much new equipment, very bulky equipment. We got Da Vinci's and all kinds of, radiology equipment that sometimes gets put up against the exhaust vents. And so we can't get these rooms circulated is one of the challenges. And then you have all these bacteria that are floating in the periphery of the room, what we call the dirty donut. And they can't get out of the room, but by movement and doors opening and closing can push this, and then it can move into the surgical field. So OR contamination of the field can develop into SSIs. And many of them, they've been able to show that contamination did come from airborne particles. And these particles were matched up in some studies as far as the exact strain that was coming from either the environment or a patient themselves landed in the incisions and caused these infections. They can also settle on the surgeon's gloves and on instruments. There was one spine study where they actually looked at and cultured the instruments during surgery and found that they were getting pretty contaminated the longer the case went on. And with spine surgery, they can go on 10 to 12 hours, some of these cases. So this correlation between airborne contamination and SSIs, particularly with deep and implant-related infections, has been published in several papers. And then the instruments, as I mentioned, that paper was in JBJS several years ago, showing the contamination to the instruments. So in operating rooms, we have a couple different types of airflows. The turbulent mixed airflow is very common, and this undergoes these irregular fluctuations or mixing. It's designed to take and dilute airborne contaminants by turbulent mixing of supplied clean, sterile air and the contaminated room air. And the TMA, as they call it, system with terminal mixing diffuses supplies air clean by HEPA filters. So the high efficiency particulate air filters, or a HEPA, is what's going to take out, a very large amount of these particulates that are in the air. So the efficiency of the ventilation system, that's influenced by multiple factors such as the position of the operating room table, the team, and who's at the team. Another thing I've seen in recent years is we used to have in the old days, because I've been doing infection control for over 40 years, on the floor, we had like either a box that designated 3 feet around the field, and you were to stay out of that area if you were not scrubbed in the field. And I very often, as a corporate director, when I was doing surveys in hospitals, doing both Joint Commission and CMS surveys for the corporation I worked for, I would take pictures of the backs of, residents or anesthesia staff and visitors that were actually had their head right over the surgeon looking into the field, especially in teaching hospitals. And it's just something that we have to be more, careful about, because these systems can't handle those million of skin scrapes that have bacteria that may be coming off of a person's skin and having a lot of people in the room. So that's one of the problems, the personnel clothing issues as far as surgical attire, making sure things are, really covered and not having hair hanging down into the field. The foot traffic we've talked about, and the surgical equipment and frequency of the door openings and closings. So we also have what was placed, and I remember when this became like, the state of the art, to have laminate airflow in your operating rooms. And in this situation, you either have a vertical or a horizontal and unidirectional type of an airflow, laminate airflow. It's not recommended by WHO. There's been no evidence to show, and the study's been done, that they actually reduce surgical site infections. It really isn't truly laminar. The concept is a curtain effect around the field and then moving that off through the exhaust vents. But when you start to get all the equipment and the people moving in and out, it disturbs all that ventilation. I remember having an outbreak of mediastinitis at one of my hospitals, and we did a study where we closed the doors, shut the lights off, and we took smoke and put it over the table, and you could actually see this laminar flow the way it was supposed to work. The minute we opened up the front door from the inner core corridor, you could actually start to see the smoke move off the table and kind of come up towards the overhead lights, which heat rises. So pulling it up and kind of moving it down into the field. But the laminar flow was so strong, it would take the smoke off the field. But when the back door got open, which led to the ICU in this hospital, you can then really see the movement of the smoke coming all the way up above the overhead lights and just pouring itself down into the surgical incision. So it's a real challenging. That's why I used to use a lot of the smoke studies to show the staff that you've got to keep these doors closed so you don't disrupt the type of ventilation system you have in place. So this new innovative technology came out several years ago, the Alluvia Non-Turbulent Surgical Air System. And so it's a small mobile device that reduces viable particles that are laden with microorganisms and their counts in the operating room by as much as 99.5%, regardless of whether laminar or turbulent mixed airflow is in use. This mobile device uses a proprietary ultraviolet technology that's combined with the HEPA filtration, and it eliminates particulates and microorganisms and returns ultra clean air to the operating room with a non-turbulent airstream. So when we have the dirty donut, we call that the periphery of the field around the back tables and around where people are moving in and out who are not scrubbed in the field. And when you put this into one corner of the room, it actually can create what's called a clean donut, as it just takes the air and continually filters it through the HEPA filter and through a UV light irradiation. So the ultra clean treated airstream from the Alluvia is not directed over the patient. Instead, it's directed up and out in a non-turbulent airstream. And the Alluvia cleans all the air in the OR 10 times in 1 hour, including high contamination areas in the periphery. It's recognized by the FDA as a Class 2 medical device. It's been used in operating rooms to produce a directed, non-turbulent, filtered airflow to remove particles and microbes. So the safety profile of the Alluvia, it's been used for about 8 years. It's currently involved in over 30,000 procedures per month without adverse events, including leaders, as you saw, at Cleveland Clinic, New York University, and Baylor. And studies continue to demonstrate reduced SSIs with the use of this device for procedures involving implants. The ASHRAE 170 guidelines allow the use when warranted by the staff or procedure under Section 0.1, as long as the room is compliant with standard requirements that ASHRAE has for an operating room. Ultraviolet irradiation, now that's completely internal, so no, there's no risk of exposure to staff or to the patient. And it does not affect the positive pressure or create cross currents. That was some concerns from some engineers thinking this might interrupt some of the flows, but it does not. So how it gets deployed in an operating room is first you identify, you should have a team, including your surgeons, infection prevention, OI managers or directors, engineering. You know, that's what I always did, always teamwork. I never did these things alone. And I get people in the room saying, okay, infection prevention, tell us the SSI rates, what's going on, who's having the highest rates right now. You know, a lot of joint arthroplasty have done, as you saw, so many different interventions that they've been successful in reducing their rates. You know, at the New England Baptist Hospital in Boston that I worked at, where they did over 12,000 procedures a year, we drove those infection rates down to 0.3. I mean, we had a 7S bundle and a whole teamwork. We didn't have this airflow at that time. I definitely would have had this in by that point. But our joint arthroplasty rate was so low, but we focused on spine fusions. They're much more challenging because of the lengths of those procedures. And also cardiovascular and thoracic are reconstructive implantation. So you want to sit down with the team and first decide, where should we start? You know, who's having some challenges with their SSIs, and we'll place it there. And then do the room assessment and unit location. So working with the manufacturer's rep, they come in and they look at what's the best place to locate this in the room. Areas with the highest level of particulate contamination and traffic, the areas with the lowest airflow velocity, called the dead zones, placed outside of the central directional flow area. And typically they're placed in the corners where there's no door or wall or air vents. And then the in-room trial evaluation and reporting, the trial process consists of intraoperative particulate and airflow monitoring that's done by this equipment. And the equipment and the on and off conditions over consecutive periods of time are done. And so you want to get a baseline of what the airflow and particulate count was in the room before, during surgery, so you can actually see, as was shown in the previous speaker who's used this, and how when the doors open, things came up, but this could kind of keep the level at a lower level as air particles. So you can get almost 50 to 70% is typically seen with this equipment. And then review the trial results and performance with your perioperative leadership team. It has built-in sensing and recording. So this is what's so unique about this, is that can actually count the particles of multiple sizes and the temperatures and humidity and the usage patterns. It will store thousands of data points over a year, and then you can take that to have actionable data and quality control. You know, it's really important when you do a return on investment and you're trying to work with your administration to, you know, justify equipment. That's what's really nice, to have this kind of quality control built into the equipment. And then in the future, there'll be other kinds of innovations on environmental monitoring, like CO2 and VOCs and room pressure that will be coming. And so there's clinical evidence in the Journal of Arthroplasty 2018, the Cleveland Clinic study of statistically significant reduction in OR bioaerosol levels with this equipment of about 60%. And then another one, Journal of Arthroplasty at the Medical College of Wisconsin, looked at close to almost 500 total joint replacement patients. They had 5 infections in the control group and no infections in the alluvia group, which was considered statistically significant. And a study that was in AGIC at Wake Forest School of Medicine, statistically significant reduction, about 50% in air bacterial levels. And then in ITCHY in March of 2020 at the Patel Institute, successful removal of airborne SARS-CoV-2. So this equipment has been deployed in hospital emergency rooms, ICUs, or units that they've closed down to make COVID units to help in the battle against air contamination with COVID. So now that's the end of the presentations, and we're going to open it up to a couple of questions that we did receive. One of the questions was, have any of you come up with some innovative ways to control the opening and closing of doors, besides some of the ones that I mentioned? But is there anything that you found has been the most successful?
One thing I can tell you, at Northside, they changed all the OR doors now, and you have either a bed switch versus a person switch. And so it's a sliding door, and you hit the person switch, and it only opens up enough to allow a person to go through, and it closes immediately. It's on a several second timer, and it closes immediately afterwards, versus if you hit the bed switch, the whole door slides open. And then I know that I know that the Alluvia system is definitely, it's in all of our obstetrical ORs as well.
Excellent. Excellent. Now, have you used or have moved away from staples? I know you talked about some other innovative post-op dressings, only because of there was a randomized clinical trial and a meta-analysis showing the association with dehiscence and infections with staples. I know ourselves, when we did a corporate evaluation of that, sending patients home when they took them out, and haven't had a couple of C-sections myself. And as you mentioned, we've got babies to take care of, they're sitting, breastfeeding, they're pushing down on our big abdomens as they are pushing against it. So we were actually very successful to actually move away. Some of them used absorbable sutures, and some went to incisional adhesives, or the incisional adhesive, the mesh that they put over it. Or if they were going to use superficial stitches, then they would use a transparent dressing. There is a new CHG dressing out now. So some are switching to that. But what do you think about staples?
I mean, honestly, there's no specific change in the surgeon's protocols as far as the hospital is concerned. I think it's really surgeon dependent and what they choose to use. Yeah. And I know each of us I use a combination of dressings depending on many different factors with the patient, but I've used everything from the Dermabond Perennial system to simple sutures to staples. And I've even used the absorbable staples in the past as well. I think it's just dependent on surgeon preference. It's dependent on cases. It's dependent on location of the incision, obesity factor. A lot of these all kind of come into play. And then I know that we all use different things. I mean, there's different gels that I've used to help minimize infection. There's the silver implanted dressings at one point that was being used with the obese population. And now I'm using an antimicrobial gel. So, I mean, there's different techniques and different things to use that are available.
Yeah, and I think you mentioned or somebody did, about working towards standardization. And we actually did do that up at New England Baptist. What we did was a study where we went and took pictures of what the post-op dressings look like with the clinical educators, got patients' permission, so we could go back to the surgeons, who often say, well, I'll see you in 6 weeks. And they didn't understand what the nurses or the PAs were seeing, or nurse practitioners, whoever is assigned for post-op, and the amount of drainage they might have, or dressings falling off, or little dehiscences. And so it was a very interesting study that we did. And we were able to just come up with, because you're right, it's surgeon preference, and it does depend on the patients for sure, especially with spines. And just, what that hospital is going to have in their inventory, and try to standardize towards that. So it isn't just, some rep hits you at the show, orthopedic meeting, and say, here, I want you to use this, and bring it in, because it can be very costly. And some of them are not, the absorbing products that have silver need to have exudate to work in. And so I've seen so many of those placed on like knees or hips that have no drainage at all. And it was just a good waste of money, really. But thank you. What about surgical irrigation? Have any of you stopped using antibiotics? Because that's kind of now trying to be placed under antimicrobial stewardship, because there's no evidence to show that the antibiotics, bacitracin, polymyxin, cefazolin, vancomycin, versus moving over, which has been mentioned, about using antiseptic, like an iodophor or a CHG, the 0.05% CHG product that's available, plus the povidone iodine. Anybody else want to address that issue about irrigation?
So I can kind of talk a little bit from the spine perspective on some of these other things. It's still like, I haven't quite seen that in a lot of the places. I was at Brown and then at Georgetown. They're still using antibiotic with irrigation. A lot of times plastic surgery is involved in a lot of these complex closures, and they also will still use irrigation. A lot of times, sometimes they'll use the pulse lavage.
Yeah.
I actually do use the iodine. I only use it superficial, just because right now, unclear of iodine transmission through the dura and kind of any impact on the neurological elements. But there is actually a spine paper that does show a reduction. So it's definitely an area of worth further study regarding that. And then just a couple of comments on the other two questions. Certainly, what's very interesting is in terms of OR traffic, one of the biggest proponents in neurosurgery and of that is VP shunts. Especially in kids, the OR traffic is, you need multiple passes, retinal scan, all this stuff to enter the room. They keep OR traffic to a minimum, but for whatever reason, that does not expand to other procedures in neurosurgery, especially spine. So one thing that people have looked to do is there's oftentimes a lot of equipment. You mentioned equipment, and so we may not be in rooms that can house all that equipment, so they're continuously coming in and out of the door. Oftentimes we will try to talk with the circulator about all the equipment we may need so that they don't leave the room and they don't have to leave unless it's a dire emergency. But certainly OR traffic is a continual problem in spine surgery. And then on the staple front, I certainly, I use them, and a lot of plastic surgeons will, sometimes they'll use like a running monocryl. But as many of the other speakers have talked about, it's very patient dependent, especially in obese patients where you have that tensile force on a spine patient going opposite. You want something to hold that. And especially on high-risk patients, you talked about surgeons seeing a patient in 6 weeks. I'm very aggressive on these high-risk patients in terms of promoting, wound clinics and stuff. Even a lot of times with apps and now with telemedicine, patients can check in with their decision and stuff. So being very proactive up front in terms of counseling and talking with these patients in the immediate perioperative period instead of just being done. But it certainly remains a challenge with spine surgery, and OR ventilation, obviously with all that stuff, is a big deal.
Oh,
we have all that equipment.
I remember the spine cases and the distances and the infections are horrendous, with all that hardware. Have any of you used any other innovative air technology? I've had experience with 3 other types of technology when I was the corporate director and implemented them in the hospitals. This is unique because it doesn't require any kind of retrofitting of the systems, like pulling an existing light out and putting a new light in and, having to install something. This you just move into the room, and which is why I always thought this was probably the easiest one to implement. Has anybody used anything else like the Indigo Clean, which is a white light technology? Or we implemented that in an orthopedic hospital down in Tennessee and had some great results. Or the other one is also ultraviolet lights, but it pulls it up through what looks like a fluorescent light box, and then the air goes through a UV light and then comes back down and circulates the air that way. But it requires installation, ahead of time. Has anybody else used anything else besides maybe the Illuvia?
We use the Illuvia.
Yeah, I tried to keep abreast of all of this. The one that intrigues me the most is a dry hydrogen peroxide technology, which can either be put in the ventilation system, the intake grill, or they do have one that could be mounted. And I know the University of Rochester is using that in orthopedics, and that will kill everything, including C. diff spores, if you can believe it, and SARS-CoV-2. But again, you have the difference between technology that requires rooms being shut down, retrofitting of light systems versus the Illuvia, which is just ready to go. It just can bring into an operating room. So this whole airspace has now kind of gotten a lot of attention in infection prevention, finally. Because for years, we've seen the studies where they were doing all these cultures of the environment, bedside tables, bed rails, privacy curtains, and then would culture air through air samplers or settling plates, but nobody talked about the air contamination. It was in the papers, but nobody mentioned it until, several years ago when finally some of this technology started to show up at our national conferences. So I think that's probably run out of time, but I want to thank you all for your great presentations and for those of you who attended this webinar. And if you have any questions, I'm sure that we can answer those. They can get in touch with us and we can get back to you. But thank you very much for attending.